Primary angioplasty has improved survival in acute myocardial infarction patients. However, cardiogenic shock is still one subset where the mortality remains very, very high. And one of the reasons probably is that these patients are very heterogeneous population and these are moving target. We don't know what is early intervention and when we are too late. So for that, Society of Coronary Angiography and Intervention has given an excellent classification to subgroup and subclassify these patients. Today, to discuss that, we have Dr. George Dangas, who is the current president of the SCAI. Welcome, Dr. Dangas.
Well, my pleasure to be here. And thank you for inviting me. Congratulations for India Live 2024. And great topic to discuss, cardiogenic shock. These patients are very sick. They don't have they're not even in the capacity to communicate very clearly regarding the past statuses and, the current complaints sometimes. That makes it more difficult. Often families are not around either. And things can move very fast, in improvement. That would be good. But unfortunately, sometimes they can move very fast in deteriorating. And for this purpose, we got to put a lot of parameters together, clinical, hemodynamic, and laboratory. And any EKG, obviously, because often we're talking about ST elevation, MI. And all of those together, it's a little bit of a moving target. So the SCAI classification try to put all of this together in a grid, let's say, that is not also a static grid. You can screen the patient and score the patient if you want up front. And then every shift, you can rescore or reassess the patient and see which way they're moving. A, for example, is the beginning of the classification, is those who are at risk. And B and C is the more classic cardiogenic shock. Then D and E is a deteriorating at the extremis, for example. And you can see if someone goes from B to C, well, that's not so good. Might as well be a little bit more aggressive to prevent D and E. On the other hand, if someone is responding, the classification letter can regress. That would be a good thing. And if it's sustained, this means you're doing something right. And this simple, one can say, tool can be very useful because in practice, we often are a little bit lost, particularly between the different services that may be following the patient. There's not only one doctor also in shock.
That's great. So how is it helped in your country to better manage these patients?
What has happened in the United States from having the classification available is that now the team can be better coordinated. So we can convene a team with the help of technology in a video conference, for example, or an audio conference, and we can have all parts from the emergency department to intensive care unit to hemodynamic support, the team itself, plus an attending cardiologist, plus anyone perhaps pertinent in that case, even pulmonary medicine sometimes. And we can all communicate based on a quickly available ways to screen the patient and assess the patient and decide very fast all together what is a proper first intervention as well as what is a downstream plan. And wherever there is a team like that formed, the so-called shock team, things have been very rewarding with improved patient outcomes, primarily due to this very facilitated communication.
That's great. In fact, now these devices are being available in our country also, and we are also moving in that direction. We are having shock teams in place. So this gives a more objective evidence as to where the patient stands and what is the next course of action. So what is your suggestion to countries which are now implementing their shock programs, how they can do better?
Well, we have many countries interested, quite frankly, to see how they can adapt this model into their reality. And SCAI at the society level is very, very willing and has already been engaged with several of those countries and the doctors, obviously, our international fellows of SCAI, let's say, who are the leaders in those societies, to see how the realities of every country can be assessed and how this SCAI classification and the whole management of the shock team can be modified in order to adapt to the reality of practicing interventional cardiology in the specific area. So I would say here, I can be an expert in my own hospital, in my own system, but this by no means indicates that I know what's happening in India. Even in many areas of India may be very different of how the shock patients are handled, which hospitals have or have not a shock team, and how the communication works, who runs the ICU and the emergency department and the cardiac unit. Is it the same people perhaps, maybe not? So all those have to be kind of, I would say, individualized for a certain area, a certain country, and a certain perhaps healthcare system within the country. And SCAI can be very, very helpful to partner with the key societies and groups in India to realize this potential.
So one of the key limitations in treating these patients is lack of data or lack of evidence in one device versus the other device. And we understand that the trial in these population is very, very difficult. Patients are very sick. Getting consent and implementing those therapies is very, very difficult, and trial is very difficult. So how do you suggest that this field can be taken forward in terms of more data and more evidence?
This is a great question, because as you say, these patients are very tough and very sick. And as I already said, limited communication at the same time, including their families perhaps even absent. So how do we even get to enroll or consider them for a clinical trial? No wonder the studies in this area have been small. And at the same time, because the classification didn't exist, there was a mixed bag of patients. Some of them included many people more at risk with lower event rates, and some of them included all the way the other end, people in extremis that perhaps were kind of bordering for a more appropriate for palliative care as opposed to true medical intervention. So by utilizing the shock team and the SCAI classification to understand where we are and what kind of people really we want to enter, then we have to see how we can move, and we're already moving in the United States for a registry, a shock registry. And every country and every region could also move in this direction. And once we reach that level, then we could help study, if you want to say, design as well as implementation through the registry that could already have given the regions a comfort level and, if you want to say, a pathway through which they collect basic demographic and other basic, very simple, not too many, critical data of the patients for the registry anyhow, for the clinical use anyhow. No different than that. But at least the mentality of understanding what kind of patients we're treating, that's going to be like very facile. And then we're going to enroll the right patient into the study we decide it's pertinent. So the mindset is very different than perhaps 5 or 10 years ago, that people were just enrolling patients with a single definition of shock, no matter what stage it was. And that, I think, led to some disappointments in the ultimate data, because we had a confusing, if you want, patient population for the study. So I think the classification helps the registry, and the registry will help the trial. That's how I think the evolution has to be.
Thank you very much. That's very informative. Thank you once again for being here, and enjoy your stay and rest of the meeting.
Thank you so much for inviting me, and congratulations on India Live 2024.
Thank you.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.